So today I'm going to talk on role of artificial intelligence in gastrointestinal tract cancers, how it transforms diagnosis, prognosis, and precision oncology. So we know that pathology decisions are basis for clinical decisions, and current diagnostic process are manual across all specialties. I've shown you some of lung cancer here, which earlier we had many FDA approved work going on. But the current focus is on GI cancers, and GI cancers are becoming a major global cancer burden. And there's a lot of biopsy volumes and increased complex cases making work tougher. So why do we need AI in pathology? So as I said, because of the increased case volume, complex oncology cases, extreme shortage of expert pathologists, need for faster standardized reporting, quality and accreditation as required for NABL and CAP protocols, and precision medicine demands precision diagnostics. So we need to integrate digital pathology in all the big data. So this is an exciting time as pathology seems fully poised to take advantage of notable advances in microscopy and computation, as also elicited by my previous speakers. So as I said that this deficiency of expert pathologists is all over the world. And if you have 40 to 50 pathologists in USA, the number of specialized pathologists in India are less than 10. Added to that, there's a lot of work causing increased stress, burnout because of the cumbersome, mundane work which require repetitive counting and reporting. And as Dr. Sushila has shown, how a pathology report can make a tremendous impact or significance in what treatment the patient is taking. So our counting in the evening fag end of the day can definitely affect 0 to 1 plus. So it's very important that we are always mentally alert, which cannot happen throughout the day. So as I said, the current challenges are also because there's a lot of inter and intra-observer agreement. And this is very well aware in prostate cancers, breast cancers, where you have so many sextant biopsies and you have to grade the biopsies. And so also in pancreatobiliary cancers and liver cancers, where there are subtle features which will help you to come to a definitive diagnosis. And as you're well aware, and even in pancreas, a diagnosis of cancer in a background and wrongly diagnosed in a background of chronic pancreatitis can lead to the clinician counseling the patient that you will not survive more than 1 year, and then you realize that it was reactive atypia which you have erroneously diagnosed as cancer. Now, just to show that now today is the era of minimally invasive surgeries. So even in GI and colonic polyps, the gastroenterologists, the medical gastroenterologists are becoming surgeons, and they are giving the EMR ESD specimens. And you can see that just for EMR ESD specimen, you get so many slides, and you're supposed to submit in entirety. You have to ink the margins. You have to see the favorable histological outcomes. You have to grade the tumor. You have to see for lymphovascular emboli. You have to see the depth of invasion. You have to comment on lateral margins. And then imagine when you're getting the surgical specimens, there's so many slides to be screened, because as you're well aware, we know that you have to give a very generous grossing of lymph nodes for adequate staging of the patient. So this has led to a boom of cases, and even in if you see in AIG, look at the number of slides and blocks we are getting over the years, where we started off with 2,000 and now it's more than 55,000. So that has actually paved the path for us also to shift to something called digital pathology, which Rohit has said, and it's nothing but a branch of pathology that focuses on data management, where you're converting your slides, your glass slides, into digitized information. So you're going for whole slide scanners to use this digital pathology. And why is it so? Because now, from the routine histopathology workflow, if you are going for a digitization of your slides, then you can use AI, and this will improve your workflow. It will be more cost efficient. It will improve your diagnostic accuracy and precision, and there's continuous improvement of the patient. So in AIG, we started adopting AI efficiency right from the time when we get the samples into our department. So our IT team has helped us to create an operational efficiency, which helps us to know how many hematology cases we have per day, how many cytology cases we have per day, and how many histopathology cases we have per day. This, I feel, is also very important because earlier, and even sometimes now, I'm continuously behind my technicians asking me, how many did we receive? How many have been submitted? What was the TAT of my small? What was the TAT of my large cases? Then imagine if we are still stuck in this, when do we go to the reporting of the cancers? I think we'll be exhausted, and sometimes we might end up in rushing up the slides. So in GI, the importance lies in early detection, because in GI, the lesions are so subtle that the lesions can be missed first by the clinician before it comes to us. So there are a lot of applications of AI in endoscopy. And I'm going to spend 1 or 2 slides on this because we have integrated histopathology with the advances which we have done in endoscopy and colonoscopy. So AI in endoscopy is used in esophagus for diagnosis of Barrett's, and particularly the dysplasia, where you know that low-grade dysplasia can be equally challenging like the 0-1 plus of HER2. In stomach, early gastric cancer is a major challenge, particularly with the increased H. pylori infection, as Dr. Tejal has told. And then for the colonic detections and the IBD cases. So in AI will help not only to diagnose the cases, but also to interpret the slides and also to predict which patients are actually at risk of developing further cancers based on their genomic and clinical data. So at AIG, we have a POEM procedure. I'll just start with one. What is POEM? It's a minimally invasive therapeutic procedure to treat motility disorders like achalasia cardia and spastic esophageal motility disorder, where the gastroenterologist will go for resection of the esophageal muscle layers. And it's a very cumbersome procedure because, you know, they have to cut the esophageal muscles, so there's chances of perforation, there are chances of hitting the vessels, patients can bleed. So we have developed an AI tool which will help in identifying the vessels as they are cutting, so that this AI tool will help our clinician to know that there is a vessel there so that he can avoid cutting it and give us a better tissue based on which we can come to our diagnosis. So this is one of the tools which we have developed in-house. And then coming to the GI cancers. Now, the 1 out of 10 gastric cancers are routinely missed, even by an expert endoscopist. And this has been shown in a systematic review and a meta-analysis, both in the East and the West. And so we have tried to incorporate AI in our endoscopy tools to identify those subtle spots or these precancerous lesions which can sometimes be missed despite an expert endoscopist, despite using the NBI technology and the other updated modalities of the endoscopy. And this AI will help in predicting the depth of gastric cancer, as was seen in the ResNet 50 system case, where they have studied almost 16,000 images from 1,000 cases of gastric cancer, and they have identified that they could have improved their detection accuracy by using AI. Now, we did one study with IIT Hyderabad, where we used optical coherence tomography for surgical demarcation of the GI tumor margins, basically to accelerate the decision making during the surgical resection of the tumors. Now, optical coherence tomography works on advanced ultrasound policy, but it uses light rather than sound. So the aim of our study was to use this optical coherence at the time of surgery. So we took some samples and we put it in saline and we sent it to IIT Hyderabad. And there they used the scanner which scanned the 3 margins. And based on the optical coherence, you can see here, this is the mucosa, which is where the light is going and it is irregular. So that means the tumor was limited to the mucosa. And later they compared it with the HND and our frozen sections. And we found that by using optical coherence tomography, the we can actually, the surgeon can predict what is the depth to which the tumor is. So he need not waste time by taking a frozen or anything. So our aim is to build a model where we will infuse this optical coherence tomography within the endoscope at the time of surgery, so that the surgeon knows that this area, his margin will not be free and he can go for advanced margins. The other role in colonoscopy is for automated polyp detections. We know that we have a lot of polyps in our population, basically because of our dietary habits. And there are two major roles of AI in colonoscopy. One is to detect this polyp, and second is to categorize the polyp, whether it is neoplastic versus non-neoplastic. And as you can see, if the polyps are very big, it's very easy for the endoscopist to identify based on the subtle morphologies and based on the NBI pit patterns on the surface of the mucosa, and based on the NICE protocol, whether it is pedunculated or flat, and based on the gross appearance, the endoscopist can also say whether it is hyperplastic versus neoplastic. But for a novice gastroenterologist or in remote places, we can use AI-assisted colonoscopy, which we also have in AIG to help our budding gastroenterologists, where you see on the right side, it's the routine colonoscopy, and on the left, the purple is the AI-powered colonoscopy, which is giving a hint to the person that, yes, that's a polyp, and it also says whether it is hyperplastic or adenomatous. And what is the role of pathologist here? And what is the role of AI for pathology? Now, basically, we need AI in adenomas to differentiate between low-grade dysplasias and the serrated adenomas or traditional adenomas, which is very important. And a lot of study is going on there because we know that there's a lot of inter and intra-observer variation. So AI can help us in adenoma detection. Also, AI can be used to triage large bowel biopsies. And there's one study which also showed that there was by using AI, it was able to segregate the hyperplastic polyps and neoplastic polyps to 97% sensitivity and 93% specificity. And AI took 175 seconds per slide to download and process the whole slide image and return a diagnostic classification. So this has resulted in a significantly shorter reporting turnaround time, particularly in neoplastic cases. And also we know that, as I said, the medical gastroenterologists are going for curation. So then the role of the pathologist is to evaluate these key favorable outcomes. So for this, I find that the digital microscopy plays a very key role wherein you can analyze the depth. So for example, if you see in the histopathology here, when the surface is eroded, it's very difficult to identify where your muscle is for us to evaluate the depth of invasion into submucosa. Yes, we can use ancillary methods by using IHC like Desmin, identify the residual muscle and then measure the depth, because anything more than SM1 indicates that the patient needs further surgical therapy. So here, if you use digital microscopy, you can find that the pathologist can give a clue to the gastroenterologist about the completeness of the surgery. So this, if you further add AI, it will help in improving the sensitivity and specificity. So this was a case where it was beyond SM1. In colorectal cancers, the other key areas where repetitive works are there is to look for tumor segmentation, tumor budding, and MSI prediction. Now, there are various studies which showed that if you use AI-based tools for colorectal carcinomas, a training set of 241 manually annotated whole slide images were taken from multiple institutes. It was validated across 6 case cohorts in 5 pathology departments, reducing the bias, and 4 different scanning systems were used. And it showed that it had a sensitivity of 100% specificity in identifying the tumor. So, why is it important? Because AI is automatically able to locate the tumor, it's able to measure the tumor burden, give you the tumor percentage, further assist in biomarker testing, and help select the tissue for NGS. So, this test has proven that you can get a near perfect sensitivity and specificity and assist the pathologist. And the other thing is AI can help in detecting the tumor cell fraction, as shown here, where 69 pathologists visually estimated the tumor cell fraction in 10 regions of interest. And this was further re-evaluated with AI. The ground truth was, however, the manual counting done by the manual pathologists. And this study concluded that AI estimates the tumor cell fraction much more accurate and much more consistent, reducing the inter-observable variability and standardizing it. And why is it important? Because, see, once we give our reports, again, the oncologist wants to know, is there adequate tumor? Can I do IHC? Can I do NGS? Can I send it for Claris USA? Can I send it for Guardian 360? So it is helping us to know in one go, giving the diagnosis and helping us with all this. So when the study was done, 95% of respondents answered that the AI tool was useful to them, and 91% said that they would definitely adopt if this tool was available to them. And the other one where AI can be used is for tumor budding at the advancing front of the tumor, which will be standardized. Now coming to the role of precision medicine. Now today, the era of precision medicine, we are stratifying individuals separately. We are not grouping them as before. So each individual's genetic profile is what is needed for the oncologist to give treatment. And that is where the role of pathologist comes. Now, just now, Dr. Sushila has shown the role of HER2 in breast. Similarly, HER2 is used in widely tumors of GI. Now, if it was a manual method, yes, I will do HND and I will do IHC and I will give as HER2 equivocal. If I have a digital platform, it is more useful that 2 or 3 pathologists will sit together and see the same report at the same time. But if I have an AI platform, as Dr. Sushila said, we can give a much more better report. Now, why is the AI important? Because as I said, AI not only quantifies, but it also looks at the various background milieu. That is, it is seeing the tumor background, the tumor infiltrating lymphocytes, the stroma, the parenchyma, and based on this, it is able to assess, which we all know is very important for PD-L1. Now, PD-L1 is an important immunotherapy marker for most of the tumors, and the expenditure for giving this treatment is enormous, and most of the patients cannot afford this. And particularly now that the oncologists repeatedly want HER2 low and PD-L1, and we need to do the TPS scores and CPS scores, you need a trained, experienced pathologist to do this. And despite your best training, if you do this counting at the fag end of the day, I'm sure we will give erroneous values. So a study has shown that AI-enabled PD-L1 interpretation identifies more patients who are PD-L1 positive at low cutoff points, and subsequently when compared to the manual reads. Also, another role of AI is not only by doing IHC and submitting that IHC slide for reading, but from your histopathology slide, by seeing that if the tumor has a mucinous morphology, it has a lot of tumor infiltrating lymphocytes, there is a medullary pattern, AI predicts that this is probably a high probability MSI high phenotype. And you can then compare it with by doing your IHC, and so you are able to give clinically impact information right at your HND that this patient is probably requires Lynch syndrome workup, is immunotherapy eligible. And so what I'm trying to say is histological biomarker scoring variability reduces the chances of observing a true drug effect in clinical trials by as much as 32%. Now also, if you see AI in EUS, now we do a lot of EUS for pancreatobiliary tumors at our center, and we need an efficient gastroenterologist, we need an efficient cytopathologist, and now we have this rapid on-site evaluations to identify these diagnoses, but again, it is the human eye. So there's a slightly, but I won't say this is totally AI, but we have now the latest Viva scope, which is based on the chromoendoscopy, where you take the whole tissue. You need not cut the tissue. You need not cut the FNB, but you stain it, and then it is able to give you a Z-stack images. And but of course, you need a trained pathologist to interpret it at the site, but it is giving you a whole slide image there. And now this, if you integrate with AI in the coming future, it will also give a prediction there that yes, 90% this is cancer, 90% this is a reactive atypia of chronic pancreatitis. So you can use it in your endoscopy room. And the other role of AI is in the mundane counting of mitosis, particularly neuroendocrine tumors of the pancreas. So you can use automated KI grading systems, which will be very helpful. And the other last one is also for the detection of micrometastasis of the lymph nodes. So according to the CAP guidelines, you have to resect 16 nodes. And in that thing, you might miss any micrometastasis, so AI can help you. So an oncologist, when he gets the information, he has so much of data across. So you need the pathologist report and then the oncologist report. So it's very stressful to, even in the tumor board meets, to compile all this. So you can have AI to compile all of this, and that's what makes you a molecular pathologist, because it helps you in summarizing your biomarkers, to do reflex testing, and to give a structured reporting. We just did one more study in AIG on IBD, because we have a hub of IBD cases, which are almost 4,000 fully established IBD cases. So we digitized our colon biopsy slides with the help of Amaranth. We ran a model on 92. We took 4 models like the colon tissue segmentation, the crypt segmentation, nuclear detection, and mitosis model. And the model was trained and taught to identify the crypts, identify the nuclei, identify what is cryptitis, cryptapsis, crypt loss from the multiple images. And then we used it on the AIG data, and then we found that there were 10 features which are very important, and a combined score gave a 84%, 88% accuracy of reporting on AI tool. Of course, there were some false positive cases, and we are trying to work out on this to get a better validator. Now we have done over 1,000 cases of images which we have fed completely with the outcome, which the results we are expecting by next month. So hopefully we'll be able to generate a commercially viable IBD tool for the market. Yes, the advantages are many, but hurdles are also there. And hurdles are in the lack of availability of slide scanners, or lack of our understanding, or acceptance by the pathologists. And of course, the ethics and patient safety is a must. So future directions are pathologist remains the final authority. AI will act as a decision support. And AI will only help in real-time diagnostic support, and it's a continuous model. Okay. This is Mira machine robotic assistant, and Mira also is saying that AI won't replace you, but someone empowered by AI definitely will. And even in my day-to-day practice, I do believe that we should adopt and embrace AI. And there's so many AI tools like ChatGPT, Copilot, Gemini, which should definitely be used, because we should think of one differential and then use that as our assistant to see what we are missing, so that we give a better diagnosis to the patient. Thank you. Thank my chairman who has helped me in this. Thank you.